Okay, where have I? All right, I'm sorry about that. I don't know what's going on. I don't know where I lost everyone. Is everyone still here? Okay, perfect. Yeah, I don't know what's been going on with the system. Never gave me a problem anytime I streamed or held any different classes, but just waiting for people to log in. Oh, I don't know. Why? What did it say on your end? From my end, said resolutions telling me like 1024 by 576 is not optimal. So, which is I'm assuming it's from my stream settings somehow that um, there it is 1024 by 576 not optimal. So I don't think that had to do with anything. Um, which video, Jay Smith, are you asking about if I'm going to upload the video to my channel? But anyways, I'm just gonna go through and talk about the coronary arteries. So they right the heart, so the left main pretty much almost like dead center in the face of the heart, the way that the patient's facing you. The left main coronary artery it separates into left ascending, uh, left left anterior descending, and left circumflex, the LAD and LCX. Then the right coronary artery, RCA, comes down the right side of the heart and wraps around the back. Okay, so basically um, that's how the circulation basically work. Um, so how many times have you heard women live longer than men? Uh, well, they kind of do because women live longer than men, not just because of the stuff that men are daring and they end up doing and ending their life, such as this lovely scene, but what doesn't kill you, hopefully, will try again. But do they really? Do women live longer than men? So the myth is busted, as you can see. Uh, Women are actually dying just as well. Um, so the male to female death ratio from coronary arteries are pretty much this is just a crude rate over the years from 1981 till 2014. But you can see it's like very comparable of how quick women are dying and how quick men are dying from coronary arteries. Heart disease killing people more than coronavirus for sure. And what do we got over here? So let's go to the actual lecture from the book. So here's the book. I'm pretty sure we saved us a ton of slides. How many slides are in here to begin with? Let me just double check. So yeah, we're not going to be going through all these slides because we just covered the majority of them. Okay. So cardiology, anatomy, we just went through the anatomy and physiology. We talked about flow rate. We talked about the conductive system. Uh, we talked about circulation, and the shock is wide state of hypoperfusion. Okay, we talked about that, and we dissected that. The acute coronary syndrome (ACS), which means there is a narrowing or plaque of some sort within the heart. It's within the coronary arteries. And next, so chest pain is best known symptom can be described as crushing, dull, heavy, or squeezing. Each feeling may describe a different issue with the heart. So that's why it's necessary to identify what kind of chest pain are we dealing with here. So does it hurt when you breathe? Does it hurt when I push on your chest? Because if it's reproducible, it may not be cardiac. So if I push on your chest and your chest hurts, you probably hit something. It doesn't seem like it's cardiac because I shouldn't be able to touch your heart if you're having chest pain. Okay, if it's cardiac related, I shouldn't be able to cause that. So does it hurt when you breathe? Maybe it's a lung problem. Maybe it's a pulmonary issue. But sometimes described as pressure or discomfort. Pain in the neck and jaw. Women always present cardiac problems are complete opposite and different than men. The women present cardiac problems as abdominal problem, like they're nauseous, they don't know what's going on, they feel they're about to throw up, and they may have pressure in their neck and jaw. Men, complete babies. When men get chest pain, ah, hand on the chest, radiating to the left arm, almost a common sign. Big giant children, that's what we are as men when we get a cardiac problem. We don't compensate well, I guess. But other symptoms is anxiety, nausea, sudden onset of sweating, uh, abnormal pulse, tachycardia or bradycardia, abnormal blood pressures. Because when you get cardiogenic shock, which means a cardiac related shock, you're going to have all these issues, and you may end up being having loss in blood pressure, which what precipitate worsening in condition, by the way. So obtain history, check your baselines, patient position of comfort. Typically sitting up. Don't lay the patient down. You're going to increase the work effort on the heart. Okay, you're going to increase exertion if you lay the person down. Okay, have them in a semi-Fowler or sitting position if possible, and transport. So treatment, provide high concentration of oxygen by non-rebreather if necessary to raise oxygen saturation to 94%. I am so glad that they changed that. Okay, they used to say, oh, just slap a non-rebreather on them and turn it up as high as you can, because 94%, okay, if your patient's oxygen between 94 and 99%, they're okay. Remember, more O's, tighten the hose. So when you have so much oxygen flowing that wasn't necessary, you're going to shrink blood vessels because you're ejecting CO2 out of the bloodstream. All right? CO2 is necessary. When you lose carbon dioxide, blood vessels shrink, raises blood pressure. So when you had this blood vessel that had an occlusion in it, but blood was going around it, and you put so much oxygen to the patient, you raise their oxygenation to 100%. You think you did great. So this occlusion that was narrowing in the artery gonna shut down and become a complete occlusion, and you just killed the collateral circulation to the rest of the cardiac muscle. So be careful. I'm so glad that they put that in there. Science is moving. I'm so happy. Patient care. So if trained and equipped and authorized, capture 12 lead. So the early sign of the 12 lead, it helps you identify cardiac issues. Okay. So when follow local protocols, whether to transmit to the hospital or not, and whether you want to take the patient maybe to a cardiac center versus just a regular facility. So indications of administering nitroglycerin. We talked about that already in the pharmacology. This is what nitroglycerin looks like. Indication of administered systolic blood pressure per protocol criteria. And our protocol in our area is above 120. If it comes up on the state question, I'm assuming they're going to keep it as 120. because this kind of became the common standard. Um, so you give it every 5 minutes. Systolic blood pressure remains greater 90 to 100, and per medical direction authorized to use this medication. So, indication of administering aspirin. Chest pain, patient is not allergic to chest pain. So, what is the common contraindication to all medications? You know, each medication got a different contraindication. What is the common contraindications to all of the medications? That would be allergic reaction. Okay, so if patient allergic to whatever medicine, even the medicine that's going to save their life, and they know they have an allergic reaction, a severe allergic reaction, not just, uh, you know, nitroglycerin makes my head hurts. Well, that's what it's supposed to do. It just lowered your blood pressure. But if they have an allergic reaction that they can get an anaphylaxis from, that type of allergic reaction is kind of a contraindication. So, a patient not allergic to aspirin, and they have no history of asthma, and have not taken the medication to prevent clotting. All right. So, have they taken any aspirin or anything that is like aspirin? Okay, within the past 24 hours. So, uh, there is no other contraindications. They're able to swallow safely. They're able to follow your commands with authorization of medical directions. There are different packaging of aspirin. I'm not going to go over it. Causes of cardiac conditions. We said heart problems can be caused by a number of disorders. Okay. Narrowing or blockage in the arteries. Fatty deposit buildup of narrow inner vessels diameter restricting the blood flow. Thrombus, which is a blood clot traveling through. Emboli can move to occlude flow of bloodstream downstream. Reduce blood supply to the myocardium, which is the exterior part of the heart muscle. There's myocardium, there's endocardium. Though, so the outside part, the myocardium, okay, the muscular part of the heart, is actually what's getting fed with oxygenated blood. So the lack of oxygen will cause the chest pain, definitely. So weak sections of the artery, like it balloons up, and that's called kind of dissection or transection or abdominal aortic dissection or abdominal aortic aneurysm. So these are thinning, or when the wall thins out of the artery, blood pressure will inflate that cracked portion of the wall, and in severe cases will cause bleeding and definitely death. So this is the difference between an aneurysm and what can happen to this aneurysm. If the wall, see these three walls around the heart, okay, they all start with the word tunica. Okay, part of the name is tunica. So the three layers from the outside in, remember AMI. Okay, tunica adventia, or outside. Tunica media, M rhymes with muscle, that's the muscular part of the vessel, and tunica intima, okay, which is right inside. And this is like a Teflon coating that enables blood to flow smoothly without causing fluid friction against the arteries. So, when one of these layers or two or more of these layers crack open, going to cause an aneurysm, okay, and this is either a birth defect or disease underlying condition or high blood pressure all the time. Okay, so this vessel is not designed for to stretch out that far, and these inner layers will crack and will cause this ballooning over here. This is the aneurysm, and this is ruptured aneurysm. So, electrical malfunction in the heart that may cause the dysrhythmia, whether it increases the heart rate, lowers the heart rate, or screws up the rhythm of the heart rate. Okay, angina pectoris or acute myocardial infarction, which is a clot that caused the portion of the heart to have non-oxygenated blood, oxygenated blood not getting to it, and congestive heart failure or CHF. So, chest pain caused by insufficient blood flow to the myocardium. We talked about that already. Death of the portion of the myocardium. So the heart blocks, they cause. I have a video that will explain this better. But when you get an occlusion to the circulation, that will feed the myocardium with oxygenated blood. Muscle tissue downstream, okay, cardiac cells will die by the millions every minute if you don't restore high concentration of oxygen or oxygenated blood flow right into that heart. So again, so this is what an infarct look like. Once a muscle dies, it dies forever. There's no way to revive it. It ends up being like when you have a leftover steak from the restaurant. You wake up next morning like, ah, what should we have for lunch? Let's have the leftover steak. You're gonna throw it in the microwave and forget about it for 4 minutes. Bring it back out, and all the edges of the steak is as hard as the sole rubber on your shoe. Okay, so this is what your heart muscle gonna look like. It's gonna lose elasticity, and it's gonna have problem pumping blood. It's gonna have problem transferring signal, cardiophysiology in general, electrophysiology in general. So basically, progression, patient sustains an MI, then it moves forward. Tachycardia, dyspnea, cyanosis, normal elevation of blood pressure, uh, diaphoresis, sweating, and pulmonary edema, fluid collecting in the lungs. So that's congestive heart failure. We talked about it. Cardiac arrest. We talked about the elements of the cardiac arrest. Early CPR. Never ever deprive a patient from an AED. And effective advanced life transport. Make sure you call for ALS, because this patient is going to need some serious interventions that a basic provider cannot give. So if there's no ALS available, get going to the hospital. Okay, or work per your protocol. So integrated post cardiac arrest care, teamwork, and coordination. Um, Again, immediate recognition activation. We talked about that. We talked about CPR. You all have CPR cards. So we're just going to go past the CPR section in its entirety. Rapid defibrillation. The sooner the better. Never miss a chance. We're going to still talking about cardiac arrest, compressions. We're just going to keep going past it. Semi-automatic, fully automatic. So most of them right now are fully automated AEDs. So the fully automated AED will eventually just tell you step by step what you need to do. I think that became a standard global wise. You got monophasic versus biphasic. So monophasic means that the signal will go from one pad into the next, basically. So have two poles on it. Biphasic means it will send half and half. So we shock adults with 360 joules, and with the biphasic, kind of like it will go back and forth just to do what it's supposed to do. And how the AED work, we talked about that, and we talked about who doesn't get the AED. So I'm saving you a bunch of slides. Fast. And we don't want to talk about cardiac arrest because, again, you all have CPR cards. I'm assuming by now you all do. Um, AED safety, we had a wonderful video that killed two girls at the same time. Mechanical devices, terminating CPR. Let's talk about that. This is kind of important. So, terminating CPR. Yes, you can stop CPR in the field according to this book. And this is the material that you're going to be tested on. So once you start resuscitation, you must continue until, spontaneous circulation occurs. So when you check pulses are back, now you can stop. Then provide rescue breathing as needed. Spontaneous circulation and rescue breathing occurs. So they get pulses back and they start breathing on their own. Another trained rescuer has taken over. So you continue CPR until someone else says, okay, I'll take over. Now you yourself can stop CPR. You turn care over to a person with a higher level of training. An ALS provider shows up, or a paramedic, county medic, whatever. You are too exhausted to continue. If you're working a code by yourself and you're about to die, it's okay. You can stop CPR because there's no sense of killing you too. So you can stop. If you can't catch your breath and you're the only one doing compressions, you can stop if you're too exhausted to continue. You receive no resuscitation orders. So somebody says, hey, my family member or this person has a DNR. Do not resuscitate order. Okay? Or we don't want anything done about it. So from a physician or an authority, per local protocol, you stop. But if they tell you, hey, he has a DNR, but we don't have the paperwork, the best thing I can tell you is call the medical direction at the hospital, at the facility that you're going to. because the chances are that the patient has been there before and they do have a copy of that DNR. That will be the best person to tell you stop CPR would be the doctor that you're going to end up taking the cardiac arrest to at the hospital. So, um, again, you when you start the resuscitation, you must continue until criteria that determine when it's not reasonable to stop without missing uh, anyone who has a chance of survival. So, arrest not witnessed by EMS personnel or a first responder. Okay. No return of spontaneous circulation after 3 rounds of CPR and rhythm check with an AED. Okay. So if you don't have an AED, it means you need to continue until rhythm check is checked. Um, so AED did not detect shockable pulse and did not deliver a shock. So again, the video about an AED, we're not going to go through that. And cardiac arrest video, AED video, coronary artery disease video, and chapter review. Woo! Man, 4 hours and 20 minutes. And I apologize. I really applaud your dedication. Trying to learn from home on a Thursday night in the middle of a quarantine, and you have to listen to me talk for 4 hours. I am terribly, terribly sorry. I wish I had less of an accent that will make it easier to understand, but there is nothing I can do about it. Uh, it is what it is. Could have been worse. Yeah, could have been somebody checking your extended vehicle warranty. So, God, coffee's so great. Anybody have questions? Oh, we lost quite a few people. There's only 7 viewers right now. We started out with 15. But people are tired. They have kids. They gotta go to work in the morning or get quarantined in the morning. One of the two conditions. How's everyone doing? Everyone's still there? Okay. So start. Wayne says I have a lot of questions. No, seriously, if you have questions, now is the time. Oh, my pleasure, Pam. Anytime. I'm terribly sorry that you have to go through this. I know that face to face interaction would have made this lecture maybe easier to endure, but at least you're probably watching this from your bed, versus being at the college. Um, so, if you guys have any further questions, you have all my contact info. I'm going to leave this lecture up for a little bit. Um, maybe a day or so, if people want to get caught up, want to go back and review some things. Uh, or maybe I have said something wrong and they want to point it out, go for it. So, uh, Sydney says 7 left standing. Extra credit for next test. Oh, probably. We should talk to Rob about that. Uh, so you get extra credit. What do I get? I'm working from home. So, yeah, my daughter's still watching TV. She's being really good about it. I'm surprised none of the 3 dogs caused an issue. But if you guys have any questions, you know how to reach out for me. Um, I don't mind if you guys want to text me. Just make sure you text me your information. Don't just text me the question. I'm going to share my info and phone number in the classroom chat. So I don't want to put it on YouTube because this is a public session. So anybody from the public can watch it and look at it. I don't. I think Rob tuned out right around the time when Ron got out, because Ron and Rob, they were just double checking that there's no technical problems with the lectures and everything's working fine. So Yeah. Well, thank you all for watching. I appreciate you hanging around for this long. I wish I was in front of you so you can ask more questions, but this is what we have. Desperate times call for desperate measures. And by far, this is the most innovative and desperate measure this class have ever gone through. I'm glad to be part of this step. Thank you for helping me out, and thank you to any other EMTs from across the nation that's going to be taking the class and need a refresh on the material. But sorry for not going through the cardiac arrest portion of it because you get most of that with the CPR class and when you get your CPR card. That would have been more waste of time. Thank you all, and until we meet again, please stay safe. Corona free is the way to be, and you all have a great day. And see you later, and